Good evening, everyone. My name's Taylor Abel. I'm Chief of Neurosurgery at Children's Hospital of Pittsburgh, and I'm going to be talking tonight about the surgical management of epilepsy. And so I'm an epilepsy surgeon. It's about, even though I do a lot of different things as a pediatric neurosurgeon, a lot of my practice is focused on epilepsy surgery. In taking care of children who have severe epilepsy. One of my disclosures, though, is that I also had epilepsy as a child. I had something called benign Rolandic epilepsy of childhood. And so that was part of the reason, that's part of what motivated me to become an epilepsy doctor, is that I had this experience when I was a child. I'm going to try to not talk for very long so that we have plenty of time for questions. And so if you do have any questions, put them in the chat. And then Megan or Sarah, is there anything else we should say before we start?
The only other thing is if you could stay muted while Dr. Abel is talking, just to kind of cut down on background noise. We would greatly appreciate that. And as Dr. Abel said, if you think of a question, put it in the chat and we will go through those once he's done his presentation. And we appreciate you all taking time out of your busy schedules to join us.
All right. So I'll start by talking about why epilepsy surgery? Why is that important? And I'll talk about some of the indications for epilepsy surgery, like reasons why we do it. Just for general education, I'll go through some examples of epilepsy surgery. And then I'll talk a little bit about minimizing surgery and maximizing outcome, because one thing that's new in epilepsy surgery is some of the technologies that we have that are different and that allow us to try to maximize quality of life after epilepsy surgery in new ways. So the reason why epilepsy surgery plays such a key role in the management of epilepsy is that as all of you know, about 1 in 26 people has epilepsy. So epilepsy is a really common disease. And 30% of people with epilepsy have what's called drug-resistant epilepsy. And drug-resistant epilepsy is when you're on 2 medicines, but you're still having seizures at all. So even if it's just 1 seizure a month or a couple of seizures a year, that's called drug-resistant epilepsy. And the reason that definition is really important is because if you have drug-resistant epilepsy, your odds of becoming seizure-free on additional medicine is about 5%. And so we know that once you have drug-resistant epilepsy, the odds of becoming seizure-free with medicine is really, really low. And so for that reason, the International League Against Epilepsy published this recent report that says that if you have drug-resistant epilepsy, you should be referred to a center where you can have a surgical evaluation to see if you might be a candidate for epilepsy surgery. And this is that report they published, and we don't go into details there, but what this report says from the International League Against Epilepsy is that if you have a brain abnormality causing seizures, that's like a brain tumor or a tangle of blood vessels or a cortical dysplasia, you should be referred for surgery as early as possible, because it doesn't necessarily mean you need to have surgery, but it means that if you have one of these brain abnormalities, we should be thinking about ways that we can cure epilepsy by removing the brain abnormality rather than giving continued medical treatment over time, which is less likely to be effective. And then this report also says if you have drug-resistant epilepsy, you should be referred to a center that can offer epilepsy surgery for a full evaluation. The other thing I should mention is that there's actually no country in the world where all candidates for epilepsy surgery are routinely evaluated. In fact, only less than 10% of people who would benefit from epilepsy surgery ultimately end up having it. And there are probably a lot of different reasons for that, but that's one of the reasons why it's important to give talks like this so that we can try to reduce the stigma around epilepsy surgery and help individuals with epilepsy get the care that they need. There's a lot of evidence for the effectiveness of epilepsy surgery. This is one of the first randomized clinical trials of epilepsy surgery, and this was specifically of temporal lobe epilepsy. But what they showed in this trial is that if you compare patients that are randomized to getting surgery to medical management, you can see that the odds of being seizure-free if you have surgery is way higher than the odds of being seizure-free with just medicine. And so this is one of the most early clinical trials that showed that. And you can see here that if you're randomized to the surgical group, your odds of being seizure-free is around 50%, which is a lot higher than the 5% in the medical group. But what's really interesting about this study is that because this study wanted to be as inclusive as possible, they included every patient who had what's called an anterior temporal lobectomy. That's just a fancy term for we remove the front part of the temporal lobe. And they included all patients, even if they only had a centimeter of the hippocampus removed. Routinely, we remove 2 or 3 centimeters of the hippocampus. And so in the real world, outside of this clinical trial, temporal lobe epilepsy surgery tends to be much more effective, up to 70 or 80% rates of seizure freedom. And so epilepsy surgery in this context can be really effective. In my line of work, since I focus on pediatric neurosurgery, this paper is really important to me. This is a study that was published recently. So it was published at a time where we already had a pretty good idea that epilepsy surgery is more effective than not doing epilepsy surgery in individuals with drug-resistant epilepsy. But in India, their healthcare system is so busy that they could randomize people to having individuals with epilepsy either having late or early epilepsy surgery just because all the hospitals had a wait list. And what they found is that individuals who had epilepsy surgery had a much higher probability of being seizure-free than individuals that did not have epilepsy surgery. And what they also found is that individuals who had epilepsy surgery, their quality of life was better, their cognition was better, and overall they did better. And so the goals of epilepsy surgery are to improve seizures, to improve quality of life, and also in children, and I say this because I'm a pediatric epilepsy surgeon, we want to improve developmental outcomes. We know that the best predictor of how someone's thinking will be and how their cognition will be long term is whether or not they will become seizure free. And we know that that actually seizure medicines can affect your thinking, and the abnormal electrical activity in your brain, even if you're not actively having seizures, can also affect your thinking and development negatively. And so these are all things we're thinking about when we are thinking about epilepsy surgery. And so for that reason, we actually try to do epilepsy surgery in kids at as early an age as we can, because the earlier we restore normal development, get seizures controlled and restore normal development, we think that means that someone's developmental outcome will be better, meaning their thinking will be better, their success in school will be better. And so those are some of the things we're thinking about with epilepsy surgery. This is an example of that, just showing that if you're seizure free, you actually end up, after epilepsy surgery, you actually end up having a higher IQ than if you were not seizure free. And so IQ is one of the ways that we measure cognitive abilities, both before and after epilepsy surgery. there are different types of epilepsy surgery that we offer. And so if you have generalized epilepsy, we're often thinking about something called vagus nerve stimulation or deep brain stimulation, or also something called responsive neurostimulation. And all of these different modalities have different levels of evidence. Um, if you have something called drop seizures, we often think about doing something called corpus callosotomy, and I'll show you. Uh, I have some slides later on to show you what that looks like and some more recent ways we have of doing that in a less invasive way. If you have what's called focal epilepsy, sometimes this means you have seizures from one part of your brain. In focal epilepsy, sometimes on an MRI of the brain, we can see a brain tumor or a focal cortical dysplasia. And if we see something like that, surgery is probably the most effective tool we have for treating epilepsy. If you have a brain tumor causing epilepsy, certain types of brain tumors, your odds of becoming seizure free is 80 or 90% after just taking that tumor out, or a tangle of blood vessels. And so if you have one of those abnormalities on your MRI, we often think about doing surgery early just because we know it's more effective than medicines for treating seizures. If there's no abnormality on the MRI, but seizures still aren't responding to medicines, we often think about doing more complex methods of surgery where we actually find out where the seizures are by placing electrodes in the brain before we do surgery. So we record directly from the brain to find out where seizures are coming from, and we use that information to actually plan the surgery in a really precise way. This is an example, a 2-year-old that was having spells of behavioral arrest, so some focal seizures. They were started on a medicine. And actually, this kid had not been referred for epilepsy surgery. This individual kind of illustrates some of the difficulties and challenges and barriers to getting epilepsy surgery. I actually met this kid through my daughter's Girl Scout troop. My daughter was having a play date, and the mom came to pick their child up and said, "What do you do for a living?" I said, "Oh, I work at Children's. I'm an epilepsy surgeon." And they're like, "Well," then this mom said, "Well, my nephew has terrible epilepsy, and they say there's nothing that they can do." And so I said, "Well, why don't you just have his mom email me and I'll take a look at everything." So it turns out that this boy had this large abnormality in his brain called a cavernoma, and so I took this out because we know that cavernomas cause seizures, and so we took this abnormality out, and he has, knock on wood, not had a seizure since the time of surgery. And this 2-year-old boy was having mini seizures a day, and unfortunately they didn't realize that surgery was an option. And so this is just an example of how for individuals with brain abnormalities that are causing seizures, it's really important to meet with someone who has experience so that you can discuss what some of the options might be. And so this child, I think part of the reason why maybe some of the other experts taking care of this child thought maybe they weren't a candidate for epilepsy surgery is they actually have a syndrome where there are multiple of these abnormalities in the brain that can cause seizures, but the seizures were really coming from this really large version of the abnormality. And so I talked with the mom that night. I saw him in clinic that week. We did surgery a week later, and it's actually been a lot longer than a year since I made this slide, and this child's doing really well and is seizure free. Still has some events on his EEG, but he's seizure free, which is great. This is a 17-year-old girl that I took care of, who's on multiple medicines and actually had a stroke around when she was born. This is what the MRI of her brain looks like. And she's still having seizures, even though she's been treated with vagus nerve stimulation. But the reason I show this particular MRI is because this is a child where, had they been referred to an epilepsy center really early in life, they that is experienced with epilepsy surgery, they probably would have had one of the most common types of epilepsy surgery, something called a hemispherotomy, where we actually make some disconnections to disconnect the stroke from the rest of the brain. And the reason it's important to be at a center that has experience with that is that if you have that surgery early in life, your odds of becoming seizure free is 80 to 90%. And this is an individual who had some weakness on one side of their body from their stroke. And so actually disconnecting the stroke doesn't make the weakness any worse because the brain is already reorganized early in life. And so this is just another example that illustrates the importance of being at a center that really has a lot of deep experience with epilepsy surgery. And the center they were at, they were told that hemispherotomy would have been too risky. But I think if she had had a hemispherotomy early in life, she probably would be seizure free right now, not even have a vagus nerve stimulator. Not that vagus nerve stimulators are great, but it's better if you don't need one and you can be seizure free. And so high quality care always incorporates the preferences of both individuals with epilepsy and their families. And I say families because I take care of children. And so the opinions of their parents and the preferences of their parents is really important because their parents are their caregivers. And so it's important that everybody knows all of their options. And it's important to remember that epilepsy surgery isn't just about becoming seizure free. It's also it can be about just reducing seizures or improving quality of life. And so I'm going to go to my next slide. This is an adult I took care of. And I know that I just showed a slide that may make it seem like I think everyone should have a hemispherotomy, but this is an adult who came to my clinic who also had a very large infarct after birth and had difficult to control seizures. And when I talked with him, his goal was he wanted his seizures to get better, but he also didn't want to lose any of his basketball skills. Playing basketball was really important to this young man. And so we actually placed electrodes in his brain so that we could record exactly where his seizures come from. And based on those recordings, we had a couple different options. One was maybe we could just remove the area that's causing the seizures. But our concern, or we could do a hemispherotomy where that has that really high rate of seizure freedom. But because of what his recordings showed, we were concerned that if we did a hemispherotomy or even a big frontal lobe resection, that it might affect his basketball skills, which was really important for him. And so we opted to do a different type of surgery called responsive neural stimulation, where we placed a stimulator into his seizure focus that detects when he's having seizures and then stimulates the part of his brain that causes seizures to stop them from happening. And so this is an example of minimizing surgery and maximizing the outcome. His seizures are now improved, but he's still able to do the things he loves, which is play basketball. And so that's an example of minimizing surgery and maximizing outcomes. But what was important is that this young man knew what all of his options were. And we were able to discuss the pros and cons of each option, and he was able to make a choice with his family about what he wanted to do. And he's doing really well now. The only downside of being a epilepsy surgeon is that after I do surgery, I don't get to see my patients long term. And so I hear that he's doing well, but I actually haven't seen him in a while. So there's a question about whether or not new technologies improve care. In epilepsy surgery, we have a lot of new technologies. Responsive neural stimulation is one of them. Advances, laser ablation is another new technology. And so some of these advances are maybe controversial because even though some of them are less invasive, which is great for avoiding a bigger type of epilepsy surgery, sometimes they're not as effective. And so there are these trade-offs in effectiveness and quality of life that we need to think about individually with each person who's considering epilepsy surgery. And so I'll show some examples of that. This is a great example of how laser ablation has really improved outcomes in a certain type of epilepsy surgery. So this really small spot here is something called the hypothalamic hamartoma. And hypothalamic hamartomas cause really severe, uh, devastating epilepsies that can affect thinking and affect development. And we know that hypothalamic hamartomas are intrinsically epileptogenic, meaning the tumor itself causes the seizures. And we know that because the French used to actually put electrodes deep into these hamartomas. And so, because they're so deep, um, approaching this through a traditional type of epilepsy surgery is highly morbid. And so, the goal is you want to stop the seizures, but not cause any other damage to the brain. And so, what groups have developed now, and what we do as a standard now, is we just place a small laser ablation probe into the hamartoma, and then we heat up the hamartoma until it goes away. And that's called stereotactic laser ablation. And by doing this stereotactic laser ablation, there's like a 90% odds of becoming seizure free after this procedure, which means it's way more effective than any of the other types of approaches we'd used for this condition before. So in that way, laser ablation is really effective. And this is an example of where I used laser ablation in a child with epilepsy of a part of the brain called the insula. The insula is a part of the brain that can cause seizures, and it's also a really difficult part of the brain to do surgery on because of all these blood vessels around it. And so, actually, if you look in the literature, the risk of having a stroke when you're doing epilepsy surgery on the insula is up to 20%. And so the risks of operating on the insula can be pretty high. But by doing a laser ablation of the insula, we can ablate the insular tissue without that risk of stroke. And so this is an example where I recorded from the insula in a young girl. She was having about 8 seizures a day. And then we did an ablation. This is what the ablation looks like long term. And she became seizure free for about a year. And now she does have occasional seizures. But it's an example of how we can avoid doing a really big surgery, but still achieve a desirable outcome that improves quality of life and reduces seizures. One of the most effective types of epilepsy surgeries that's been around since the 1940s is something called a corpus callosotomy. This is a type of surgery that we offer really commonly in children and young adults with Lennox-Gastaut type epilepsy, which is a type of epilepsy that's commonly associated with what's called drop seizures. And these are seizures where when you suddenly have a seizure that spreads very quickly, and you can fall and hit your head. So these seizures are associated with injury and can really be difficult for patients and families. And so, as you can imagine, in the 1940s, we really didn't have effective medicines for epilepsy. And so this surgery has been around a really long time. But the way the surgery used to be done is through a really large incision and a large craniotomy, which means opening in the bone. And then a surgeon would then go between the two hemispheres of the brain to actually disconnect the corpus callosum surgically. And as you can imagine, that would be a really difficult procedure to get through. But the reason why surgeons did it is because this is one of the most effective things we can do for drop seizures and other big generalized seizures. And so if you compare corpus callosotomy to vagus nerve stimulation, about half of patients who have corpus callosotomy will never have drop seizures again after this procedure, whereas only about 20% of patients with VNS will stop having drop seizures. If you're looking at a 50% reduction in drop seizures, so this is maybe if you have 8 drop seizures a day, you would go to having 4. It's about 80% of individuals who have corpus callosotomy and about 50% of individuals who have VNS. So corpus callosotomy is one of the most effective surgeries we can offer. For certain seizure types. But these days, we actually have a new way of doing the surgery where rather than having to do a big incision on the head, we can actually place these small ports that allow us to place a laser ablation probe along the corpus callosum and do a corpus callosotomy without even making a big incision. And so you can see here that this is all we have to do, and we don't even have to make incisions here. We use a special CT scanner and a special robot to place these ports. And then we're able to perform an ablation that is just as effective as a traditional open microsurgical corpus callosotomy, like the one that I showed a picture of earlier. And so this is a recent systematic review we performed in about 85 patients that shows that this procedure is just as effective as the traditional open surgery. So I hope this has been helpful in seeing different types of epilepsy surgery and understanding how we think about things and what types of options are available. And I hope I illustrated the point that epilepsy surgery plays a really critical role in epilepsy care. And the other thing I want to drive home is that I think shared decision making with a team you really trust is really important to overcoming difficult decision making obstacles. And there are a lot of options that are available that you can think through if seizures are not well controlled. So that's my talk. I spoke for almost 30 minutes, but I wanted to leave a lot of time for questions. And so with that, feel free to ask anything you'd like.
And Dr. Abel, we did have one question. I believe you may have answered it in your talk about the 2-year-old boy with the large brain abnormality. I just want to clarify, you did state that other teams had found the abnormality before, but because of the other small abnormalities that that child had, they didn't feel he was a good candidate for the surgery. Is that correct?
Yeah, it's I think there were a couple things going on there. One is that this was during the pandemic. And so I think we all remember it was a little bit more difficult to get in to see an expert during the pandemic. Two, I think it's difficult for me to put myself in somebody else's shoes to know exactly why they wouldn't have offered a surgical approach because I would have done surgery right away if seeing something like that. And so it's difficult for me to put myself into somebody else's shoes, but it is important. But I think it shows the point that it's important to see an experienced epilepsy surgery center kind of early in your evaluation, just so you can know what all the options are.
Awesome. Thank you so much. If you have any other questions, please feel free to put them in the chat.
So while we're waiting to see if anybody puts anything in the chat, you mentioned trying to find a specific epilepsy center that has, good experience. What can people look for to kind of know if they're in the right place to know they have a, a good epilepsy surgery team.
Yeah, I think it's great. I think the NAEC does have standards for level 4 epilepsy centers. And so one of the requirements is that there's a fellowship trained epilepsy surgeon to be a level 4 epilepsy center. So I think making sure you're at a level 4 epilepsy center is important. But then also you can ask some basic questions like, for example, you could say, how many hemispherotomies does your center perform a year? And at some centers, it's like one every couple years. And for example, at our centers, it's you know, we have years where we do 8 to 10 of them. And so we just have more experience with it. Or the same thing with invasive monitoring, where you have to put electrodes in the brain. How many do you do a year? There's some centers that maybe only do this once or twice a year. We do it once a week. And so I think you can ask questions about volume. The other resource that is really great is the Pediatric Epilepsy Surgery Alliance. Even though it's the Pediatric Epilepsy Surgery Alliance, I think their information is also great for adults who are considering epilepsy surgery. And this is an organization that was started by the mom of a child who she's a lawyer, and she has a child who had epilepsy surgery. And her experience was that she just didn't understand what was going on or what she was going through, and had a lot of questions. And the surgical team didn't really prepare her for what her and her child went through. And so she started this organization that really provides information to families. So they have a great website that has puts language into uses plain language descriptions of epilepsy surgeries. They have a peer support program. So if your child's going through epilepsy surgery, they can connect you with a peer supporter. And so they really have a lot of like great resources. And so that's another resource where maybe through talking with a peer supporter, you can sort out if you're, what sorts of questions you should be asking. And so
Thank
those
you.
are a few things you can do. Yeah.
Yeah, thank you.
And we do have some more questions in the chat. Tanya would like to know, do insurance companies drive some of the decision making?
That's a great question. The answer is yes. Yeah, they can. I'd say in Pennsylvania, specifically at our hospital, this is the only hospital I've worked at in Pennsylvania, Children's. We've had really good luck with the insurance companies we work with. I can count on one hand the number of insurance denials we've had. But that is very different than the experience that other surgeons have had in different states. And so I just got an email before starting this talk from a surgeon out of state who said, have you had a denial for this because I have a child that really needs this procedure and they're not offering it? Some of why this is that the insurance companies, they can sometimes say, well, this treatment is not approved by the FDA, so we will not cover it. The challenge, though, is that to get FDA approval for a treatment, you have to go through all these steps. And oftentimes, specifically in pediatrics, we don't get device approvals in kids because kids oftentimes don't get clinical trials the way that adults do. And so we often don't get an FDA approved indication for certain treatment options. And so that's why a lot of my pediatric neurosurgery colleagues in other states can have difficulty getting approvals. And so if you have several options for epilepsy surgery and one of them is not approved, the truth is that most families cannot pay out of pocket. We know that the number one cause of bankruptcy in the United States is medical bills. And families often don't have the resources to pay for medical costs out of pocket. And so if there are multiple options and one of them's covered for insurance, that option might be better than not having any option. And so when these things come up, we definitely want to work with families and talk about what different options might be that might be covered by insurance. But this does come up, thankfully not very much in our community, but I know it happens elsewhere for sure.
Great question. Tracy would like to know, why do seizures return to the other side of the brain after you've had the surgery?
Great question, Tracy. Tracy, actually, can you explain your question a little bit more? I just want to make sure I understand the question as good as possible. Seizures don't all, it depends on the type of epilepsy surgery, but seizures usually don't, the goal is to not have them return. There are some types of
Can you hear me?
yes.
Okay.
Tracy, yes, go ahead. I'd love to understand a little bit better, just to make sure I answer your question well.
I had brain surgery on the front right temporal lobe. They removed 4 dead brain tissues that was causing my seizures. And then I almost went a year seizure free and the seizures come back. And they
Yeah.
did another EEG, you know, with me having seizures and said now they're coming from the other side of the brain.
Oh, yeah. Yeah. Without knowing all of the details of your situation, seizures can, it could be two different things. It could be that seizures were already coming from both sides, but it wasn't recognized because they were coming way more from one side than the other.
Okay.
That could be one thing that happened, and that's something we do see sometimes. The other thing that can sometimes happen is, and one of the reasons why in pediatrics we try to do epilepsy surgery as early in life as we can, is one thing that can happen is we now recognize that epilepsy is a degenerative disease, and that the longer you have epilepsy, the more difficult it may be to control certain types of epilepsies, and that actually having uncontrolled seizures over a period of time may start to recruit other areas of the brain and cause seizures elsewhere. That's something called secondary epileptogenesis. And it doesn't happen with all types of epilepsies, but it can happen with some types of epilepsies. And it's probably one of the reasons why the longer you wait to have epilepsy surgery, it seems to be associated with a higher rate of seizures after surgery. So all that to say, there could be some different reasons for that I just because I don't know all the details, but it can happen. And I'm sorry to hear that.
Thank you for your question, Tracy. Tiffany would like to know what your opinion is on intranasal versus rectal antiepileptics in the school setting.
Great question. Because I'm a surgeon, I will defer to my neurology colleagues on this question. Just because as a surgeon, I end up not being the person that prescribes either of those medicines. And so I would refer you to maybe ask your neurologist about it. Sorry that I can't answer that, but I promise I won't answer anything I'm not an expert on.
I think this one's more of a comment, but if you could maybe elaborate on this. Someone said, Myra said that she did not realize until recently that certain birthmarks should be evaluated due to seizure concerns, i.e. a mark very near the eye, for example. Is this?
Myra, if you're able to talk, I'd love to know more about your question.
Hi, can you hear me?
Yeah. Hi, Myra.
Yeah. Hi. So it wasn't really a question. I found this out because I am a new grandmother. The little one was born in November, and he was born with what we thought was a birthmark, starting at the outer corner of his right eye and going back across his temple, in kind of like a V shape. And we thought, oh, that's kind of just a really cool birthmark. But when he was seen by the pediatrician for like his 2-month appointment, they said, well, it didn't really, they thought maybe it would kind of fade a little bit over time. It really was looking about the same. And because it was so near the eye, they wanted him further evaluated, just with the concern that it might be involved vascularly with the eye, and that also could lead to seizures, they told my daughter.
Yeah. It's really interesting that you bring that up. Believe it or not, there are a lot of conditions like that where we will see a sign of a syndrome or a condition on the skin, whether it looks like a birthmark or a freckle that is not really a freckle, but something different. And it leads us to understand that there's something else going on, some type of genetic syndrome that can be associated with seizures or something else. So it's really I'm glad to hear that you had a team that recognized that and then sounds like did an evaluation after to look into it further. I had an instance where I was at the pool and I saw one of our friends' sons had a skin mark that is characteristic of a certain type of cancer disorder. And I wouldn't have seen this if I weren't at the pool hanging out with this family, but I recognized this and we got him to see a doctor, and now he got a brain scan of his brain and had a brain tumor. So these skin conditions can sometimes indicate other things going on that pediatricians will recognize and do further testing for.
I learned something new with that as well. And Dr. Abel, can you tell us what the birthmark looks like that's the sign of cancer so we can all look out for that in our loved ones?
Actually, there are like different conditions that can do this. But the one I was talking about was there's something called a cafe au lait spot. And that's a type of mark you can be born with that indicates a condition called neurofibromatosis, which is associated with brain tumors. But tuberous sclerosis, which is a condition frequently associated with epilepsy, that can also have some skin findings associated with it. So there are different conditions. There's a condition called Sturge-Weber syndrome that's associated with like port wine stain, and that is frequently associated with seizures, for example, but other findings also that need to be followed carefully.
Learning a lot tonight. We have another question from Cole. He said, you mentioned that the younger the patient, the better the outcome. I know you're pediatric only, but is there an age where you would not consider surgery or surgery wouldn't produce much of an outcome? And what's the oldest patient you're familiar with?
Well, this is a great question. And I think as surgery becomes safer, I think the way people think about age and epilepsy surgery is evolving. And so, in fact, I'll go back to my slide where apologize for taking a little time to go through my slides here. In this ILAE commission report, they actually talk about that very question. And because there used to be a few things that would just prevent, that seem to be barriers to getting individuals the care that they need and deserve, or options to have the care they need and deserve. And being elderly is sometimes one of those things where it's viewed as someone is older, and so maybe they would not have as many years to benefit from epilepsy surgery, so maybe we should not be referring them. But this report states very clearly that that epilepsy surgery should be considered even in older patients. And I think they say don't quote me on this because I didn't read the report like yesterday, but I think they say like up to age 80. Though I'd need to reread the report to see exactly what they said. The oldest patient I'm personally familiar with, maybe it's 70s. But that's because I haven't taken care of older patients older than like 40 for quite a while. Does that answer your question? I think the other population where I see a lot of barriers to epilepsy surgery are children who have a lot of who have significant disabilities. I think sometimes the thinking is maybe this won't help as much because of everything else that's going on. And I think that's just something that we need to notice, recognize, and just ensure that these kids have all the same options as everyone else. So that was a great question.
I was actually thinking about asking you about your perspective about surgery for children who also have a lot of other disabilities. I worked for a long time for an agency supporting people with intellectual disabilities, and unfortunately, we often found that unless we advocated for all of the options, unfortunately, there was a lot of the medical field that didn't give us all the options because of that additional developmental disability diagnosis. So it's a struggle. It's definitely an area where people deserve to have the same treatment options.
Yeah, absolutely. Absolutely.
Thank you, Dr. Abel. And we have one last question from Tracy again. She said, my short-term memory loss is from my surgery, they say. Do you know why?
So it's a great question. After I'll speak in a general sense about temporal lobe epilepsy surgery, but often with temporal lobe epilepsy surgery, a part of the brain called the hippocampus is removed. And that part of the brain can play an important role in short-term memory. And so sometimes short-term memory can be affected after surgeries like that. And I think if you're experiencing that, one thing you can do that perhaps you've already done with your epilepsy center is work with a neuropsychologist to have it formally measured. And so you can make sure that your team and you are doing everything that you can do to optimize your life with anything that's come up like this. And so it's a great question.
And we actually had another one come through from Elizabeth. She said, you mentioned surgery being used for decreasing seizures, but also improving quality of life. Can epilepsy surgery be useful in cases where seizures are controlled or infrequent by the EEG, but the EEG is very active overall?
This is a really great question. And this is also something, this is a big debate in the field right now. Is the traditional view on epilepsy surgery is that we should only be doing epilepsy surgery for uncontrolled seizures. The reason that view is changing is because there's new evidence that shows that even just having interictal discharges, which are the brain discharges associated with epilepsy between when you're having seizures, we now recognize that interictal discharges, especially when they're very frequent, are an independent predictor of having a lower IQ. And so we know that the EEG activity between seizures can affect cognitive development, can affect your thinking broadly. So for that reason, it's a debate in the field. My view is that we probably need to start thinking very carefully about offering surgery in these conditions. And I can think of, and we even have patients here where this is the reason we offer surgery, is because there are very frequent interictal abnormalities. And so we'll put electrodes in the brain to figure out where those are and then take out that part of the brain. We do this in very select cases where, for example, I recorded from a young girl's brain just last week. And the reason we implanted electrodes is because she had very frequent interictal discharges and she was starting to have a decline in her neuropsychological testing. So her IQ was decreasing, and we wanted to do everything we could to stop that. So so we do think about it, but we think about it very carefully because it is a little bit, there's some debate about what's best in these situations.
Thank you, Dr. Abel. It looks like that might be our last question for the evening. If anyone else has any other questions, please put them in the chat.
Please feel free to reach out if you have any questions. And my email address is easy to find on the internet if you need it. And there are a lot of great resources out there. Thanks for your attention.
And thank you, Dr. Abel, for joining us tonight. It was a very, very informative presentation, and I know a lot of us got a lot out of it.
Yes, and again, thank you everybody who chose to spend part of your evening with us. We know that lives are busy, so thank you again. And if Megan and I can help any of you with anything, please feel free to reach out to us. We can help connect you with Dr. Abel if need be, or just help you with anything that you need. Epilepsy related, anyway.
And have a wonderful evening, everyone.
Thanks, everyone. Have a great night.
Take care.